Hello, I'm Michael Hainsworth. I'm backstage at the Arcadian Court for the 2023 Regent Debate. Be it resolved, competition will save Canada's broken healthcare system. Joining me in advance of the four participants debating this exact topic is the former federal leader of the official opposition, Tom Mulcair. Thank you for joining us.
Good to be with you, Michael.
If there is no debating that the healthcare system is broken, what broke it?
Well, I think that it depends on who you are and what angle you're coming at it from, because you are hearing that a great deal right now. From Mr. Poilievre, that's one of his favorite terms, everything is broken. Mr. Trudeau, though, recently admitted that it wasn't working, and to the untrained eye, that seems a lot like broken. Right. And so if we're starting from that admission that the 60 years or so since we looked at this for the first time, brought it into force, it's changed a great deal. And I think more than anything else, it has to be adapted to that new reality. Competition, as such, is one way of arguing the bringing in of more private care. But let's look at how we got there and what the difference is with how the solutions we're coming up with today, Michael. In the early 60s, John Diefenbaker is in power as Prime Minister. He commissions a former Supreme Court judge, Emmett Hall, to do a vast study of the healthcare system. Now, he was from Saskatchewan. That was his political base. And in Saskatchewan, NDP had just brought in Medicare. It was something new. So I think that all three major political parties have something to brag about in terms of bringing in Medicare, because the NDP had the idea and brought it in the first province, Saskatchewan. John Diefenbaker studied it for 3 years with this. They went to 70 different hearings across Canada. They commissioned dozens of studies. They heard from 400 experts, institutes, and groups. And they put together a massive report after 3 years of hard work. Then Pearson came in, started negotiating with the provinces, and that's the system that we've always been proud of. But right now we know that there are things in what was decided 60 years ago that are just not working today. And when something's not working, you've got to try something else. The problem is, in my view, that what we're doing now, especially with Bill 60 that was just introduced by the Ford government, I don't think we've taken the time to do the proper type of studying that I just described. We've got something that arrives as the result, whereas you haven't done the legwork first to determine whether or not it's the best result.
There has been a lot of discussion about the possibility that the real issue is that we really don't know how much healthcare costs in this country. And that just absolutely surprises me, that the solution to not really knowing how much it costs for cataract surgery, the solution isn't to figure it out and then ultimately come up with a way of delivering that service, but to just hand it off to the private sector. How does that play out in your mind when we think about the idea that, well, if we give it to the private sector, there'll be competition. If there's competition, it'll be cheaper.
Well, exactly. I mean, that's why you have to do the legwork first and not arrive with the conclusion and then say, well, we'll figure it out after. Because the studies that have been done, and there have been studies done on it, tend to show that if you were to charge the full price that is assumed in the public sector, the private sector would never be able to do it for the same amount. So there is a certain amount of subcontracting going on right now in some provinces for things that are rote and repetitious, given to private clinics, things like cataract surgery that you just mentioned, hips, knees, that type of thing, repeat work. And yes, they can do it at a fixed price, and overall it takes pressure off the system, especially as we're coming out of the pandemic. There's a large backlog, a lot of people suffering and in need of care, so you've got to be more creative. And this is why Trudeau was able to use the word innovative to describe the idea of Doug Ford. But Bill 60 wasn't the result of thoughtful consultation and work being brought in. It was just dropped on the table this week, and now we're going to be studying it. It's proceeding backwards.
Well, it may be cart before the horse when it comes to solution, figuring out what the problem is. Do we even have the time to put into going back as far as the Diefenbaker era, as far as Tommy Douglas, and figuring out what went wrong along the way when we have such a remarkable backlog?
Well, a big study was just published last June in The Lancet that looked at the last 10 years of delivery of healthcare in Great Britain. So very much the same siren song. Look, let's start saving money. Let's offload a lot of this to the private sector. But if you look at outcomes, results, actually the results aren't there. So it's an ideology. It's a belief that this should make things better, But the evidence of that, and that's what these decisions should be based on, evidence, is just not there.
So it doesn't sound like you're arguing against the idea that competition is good. You're arguing against the idea that we just don't have the facts to begin with.
If I say I'm going to have a competition with you and we're going to see who can get to the top of Everest the faster, and you get first pick of all of the Sherpas, and if an accident happens with your expedition, it still winds up with me. Is that competition? Are we on an even playing field? You're going to take the best cases. The private sector gets to pick and choose. They'll point to their results and say, look, we're more efficient, we're doing a better job. The public system has to take all comers, no matter what their condition in life, no matter what the the other conditions that the person might have. And that's why you've got to compare comparables if you're going to be able to argue that you've actually got a better result.
We talk a lot about how Canada is a single-payer system, but we're also a multi-player system.
Right.
And that isn't unique around the world. There are many healthcare systems. We talk about New Zealand, Australia, the UK as well. They all have some variation of the same theme. And there is success seen elsewhere. Countries like New Zealand and Australia, on a per capita basis, pay way less for healthcare than we do. Is there not room to reduce costs?
Oh, absolutely. And there are countries that have a mixed system, private, public. There are hospitals that belong to the private sector. They have a schedule of costs and fees that they're allowed to charge to the government for any number of things. France, very socialized country. It's not difficult to get to a family doctor in France. No, there's no backlog. You don't have, like in Canada, millions of people without a family doctor, and you can get the care. But it's a mix of your private insurance, what they would call a mutuelle, your mutual insurance, and the government, and guess what? It works. So there are solutions that can be found, and the examples do exist out there. The best province in Canada for the most extensive pharmacare coverage, Quebec. There were people arguing, if you're going to have pharmacare coming out of Ottawa helping the provinces, it's got to be 100% publicly driven. The Quebec model takes the private insurance, didn't get rid of them. For people who don't have private insurance, it goes with the public system, and guess what? It's got the best result, and that's all that matters, is the result.
So we're going down this path. To your argument, and which you'll tell the crowd gathered shortly, that you feel that we're putting that cart before the horse by not doing the research necessary to figure out what's broken in the system and how to deal with the cost overruns that we're seeing. But it's coming anyway. As you point out, in Ontario, Mr. Ford already has Bill 60 on the go. What do you see as the best case solution to addressing the issue? Because if it's coming, we have to deal with it.
Well, some of the best work on this issue has been done, in fact, by the C.D. Howe Institute. A study that it commissioned and put together in 2015 remains a landmark study on the issue. So it's a complex issue, and anybody who thinks that they can come with a single shot to fix everything is simply mistaken, doesn't understand the complexity of it. I just gave the example of pharmacare, where you had a mixed system, private insurers, public insurers. It works, it provides the result. We've got to do the same thing here. Now, of course, once Bill 60 is in place, they'll say, well, it's saving money on this or that or the other procedure. But if you look at it, it's sorely lacking in terms of inspections, in terms of regulation, licensure. Enforcement is going to be notably weak. The same thing that gave rise to things like seniors' residences, whether it was in Ontario, in Bobcaygeon, or in Dorval, Quebec, these horror stories where we had to bring in the army during the pandemic, that was private. And it wasn't regulated, and there was no enforcement of existing rules. So we've got a history of being weak on enforcement, and if we are going to go down that path, we have to make sure that the College of Physicians and Surgeons is in there regularly with a full right to inspect, that the College of Nurses is in there regularly with a full right to inspect. Talking about competition, one of the things that the law opens up, Bill 60 opens up to competition for people who aren't licensed and don't have full qualifications, and still giving them the title. Now that in and of itself is a theoretical model where you say, yeah, but there are people being held back. But if you're not able to ensure public protection, then a lot will be lost.
So what you're arguing here is that not only have we not figured out what the problem is before we came up with a solution, but then the enforcement and the monitoring of that solution is weak as well. What's the solution to that in your mind?
Well, Canada, and this is not unique to Ontario, Canada generally, we're not good at enforcement. We're very polite. We apologize to ATMs. When I was the chair of a large regulatory agency in Quebec that oversaw all of the professions, a job I did for 6 years before going into politics, I could tell you that I worked a lot with Americans. I was the first Canadian elected to the board of the Council on Licensure Enforcement and Regulations of the U.S. These guys had badges. This was part of the state policing power, and they didn't fool around. In Canada, we saw what happened with the seniors' residences, private outfits close to the people in the government, whether it was in Ontario or Quebec or elsewhere, no real enforcement, no application of the rules. So we're going to have to get this right. If you're going to be saying, oh, you don't like competition, why are you against competition? No, competition on an even playing field where there's inspection, there's certification, there's licensure, and we're able to validate that all of the rules are being followed, that's something that I'd welcome.
There are concerns that the money actually does exist to fill in the gaps right now, but by example, in the province of Ontario, there was a massive tax cut to the tune of $7-8 billion. Yeah. And that is almost exactly the shortfall that the nursing industry and the doctors are arguing is required to fill and get those operating rooms.
It's almost exactly what the federal government just gave to Ontario to fill the gap, yeah.
Are you confident that the federal government is going to have sufficient strings attached to the provinces to ensure that the money being funneled from the federal level to the provincial level isn't just going to go to additional tax cuts?
That's a great question. And I think that one of the things that they have to do is simply demand and obtain, as a condition precedent of handing any money over, all of the information that allows them to see wait times, costs, ability to deliver good care, and the scope of what's being covered right now. I think that those are all very valid questions. Without saying that you think that the federal government has the ability to lecture on the delivery of healthcare, because if you look at the three fields where the feds do deliver healthcare, it's federal penitentiaries, First Nations, Inuit, and Métis communities, and the armed forces. I don't think that that's a really great track record.
So nobody's doing it right?
Well, I think that the feds are not in a position to lecture. And I think that if the people who are going to determine whether their system's working or not are the people in every province. But there is objective information that can be given, and that's one of the things that Trudeau is asking for, and every province so far has said, fine, we'll publish that information, we'll be transparent about it.
Who elsewhere in the world is doing the single-payer, multiplayer method of healthcare delivery correctly?
I mean, you've got any number of countries right now who have a single-payer system. But everybody is trying to chip away at it, and it's mostly people who think that they can make a good dollar by doing some part of it for themselves. I mean, Bill 60, the full title should be Bill 60 and Take Back 40, because they're going to be able to take back a lot of the money that's going into it from the government, the people who are in charge of these clinics. Is anybody going to be ensuring the result? And what happens when there's a flub? And there will be. So you go to a private clinic, they get their money to do the work, and one of the patients has a problem. You know as well as I do where that patient winds up, in the public system, getting themselves fixed up, getting things corrected. Who gets the bill back for that? None of that you'll find in Bill 60.
I'm having difficulty because we were hoping that Christy Clark would be here as well. We would get both sides of this, and so I find myself arguing on her side of this equation.
But you're doing a good job.
And the C.D. Howe Institute has done some remarkable research that shows that.
I'm the first one to say it. Yeah.
As you just pointed out, starting in 2015, there's some remarkable research that shows that we have a problem, and there is a solution where it can work hand in hand. I was expecting you to come in and sit down beside me here and be ferociously against the idea of competition. And I'm not really getting a sense of that. I'm getting a sense that you just feel that there are blanks that need to be filled in.
Well, it's a bit of a mug's game to say that the issue is competition, because it's not simply a question of competition, because if it's not on an even playing field, you could probably trounce me playing tennis, but you wouldn't want to get on play hockey against me. I mean, it depends on what you're considering competition. So if you've got people who are doing completely different things, one person has to support every single patient who walks through the door. They don't get to pick and choose. And you look at a private clinic like Shouldice, I mean, they get to pick and choose. If you're a smoker or you're way overweight, they'll tell you that you're not coming into their clinic. They're sending you over to the public sector. Well, is that competition? Or is that cherry picking the best patients to boast about a better outcome?
So it sounds like one of the solutions is to ensure that there is a universal wait list.
Exactly.
And you just work your way from the top down to the bottom.
There has to be a single wicket, because if you allow the private clinics to choose the best patients, in other words, the ones with no underlying condition, no weight problem, no addictions or anything like that, then they're going to have great results. But everybody else is going to wind up in the public system, and it's a vicious circle.
When I talked to Don Drummond about this exact issue on a recent episode of the podcast, he had a solution that seemed very similar to gasoline futures, of all things. Is that, if I can parrot it correctly, what he's suggesting is you take that list and you take about 10% or so of it and you set that aside. And then all of those clinics have to essentially bid on the cost to attend to those particular patients. But then, because there's always going to be overflow, there's always going to be bad times where you have that rush, that you would then take that additional load and be able to bid separately on that. Do you feel that there is a financial services sector style solution to this issue?
It could be one of the solutions that could be looked at. But I think that what you're doing is you're proving my hypothesis from the start, that we have put the cart before the horse. And we're looking at the result, which is Bill 60, but this type of question is absolutely not addressed in there. But it should have been, and it should have been looked at before.
Mr. Ford has insisted that you will pay for your health care with your OHIP card, not your credit card.
Yeah.
You don't believe him?
Oh, I absolutely believe him. And if it turns out to be differently, there's going to be hell to pay for him politically. But who's going to go after the clinic that says, well, this is the HIP that OHIP is willing to pay, but we've got one over here, it's a couple of $1,000 more, made of much better stuff, lighter, and it'll be better. Do you want to buy that? And you can apply that to any number of these operations. And so are you going to be upselling? Are you going to be telling people, well, we have the private clinic and you're going to get on, we're going to bring you in, but you're going to have to spend a couple of nights at our hospital because we like keeping an eye on you after. Whereas in the public sector, you would just be allowed to go home because there's no reason to keep you. Mm-hmm. So who's going to be enforcing that? Who's going to be setting down the rules for that? And who's actually going to be caring about it? Because if you're the person who's been on a waiting list for 9 months and you can barely walk anymore because you need a hip replacement, and somebody starts selling you that stuff, you're going to say yes. And the last thing you're going to do is go complain to the government. So there has to be an active enforcement of existing rules, and none of those rules have been set down yet. There's a large rule-making power under Bill 60, but it still has to be fleshed out.
So then what's the political solution to that lack of enforcement problem?
Well, there are two sides to it. One is identifying what has to be done. That prior work has simply not taken place in the preparation of Bill 60. And with regard to enforcement, it's the same type of monitoring and reporting that you have to have. When the tragedies took place in the private seniors' residences here in Ontario, it was revealed that the government had actually reduced the number of inspectors since they came to power. Because when if you've got a very right-wing approach, you say, oh, government, regulation, inspectors, this is the type of red tape we want to get rid of. Those regulations exist for one purpose alone, which is to protect the public. Mm-hmm. So you don't get rid of them lightly. And then once they are there, if you have a rule, it has to be applied. It has to be enforced.
So when you step up onto the dais to talk to the assembled crowd of very powerful people, what's the key message you want them to walk away with?
That it's clear as a bell that 60 years later it's time for a reset, but the work has to be done before, and you don't arrive with the result without having done the prior work.
Thank you so much for your time and insight.
Good to be with you, Michael.
Joining us is Tom Mulcair, the former federal leader of the official opposition. For more on this topic, of course, go to cdhow.org. I'm Michael Hainsworth. Thanks for joining us.